Oh dear, that's okay. There are cycles of growth that you can grow faster and slower. Some children grow slower in the winter, but overall they keep to their centiles. Crossing your centiles, going up or down, is an unusual thing and needs some thought. And as I said, parental height's an indication of the genetic influence of height, but most children who come to clinic will inevitably be those who are short for family. It's worth also saying that adults are enormously unreliable about their height, and if they feel that it's an important factor, they'll often tell you that they're much taller than they are. The definition of a normal growth hormone status is to have a normal growth velocity. That's how people have determined the cutoffs in terms of growth hormone testing. So a child who's growing at a normal speed has a normal growth hormone secretion. You don't necessarily have to do a test in order to tell you that. And here we are. Here's a typical child who turns up to clinic. They are short. They're short for their family. They're below the 0.4 percentile. Going over the same kind of list, yes, you would consider doing celiac antibodies, thyroid function. IGF-1 and IGF-BP3 are markers of growth hormone status. They are helpful but not terrifically accurate. They're more helpful in the kind of extremes, in that, you know, if someone's got a very high IGF-1, they're unlikely to have growth hormone deficiency. But if they're not a sort of replacement for doing growth hormone testing. In terms of genetic testing, I would always think about, in a girl who is short, think about Turner syndrome, do a karyotype. Although a proportion of girls with Turner syndrome do have some very typical physical features, some of them don't, and that is one issue where things can get missed over years, where people don't look for Turner syndrome. Bone age starts to be helpful once you get to 2, 3, 4 years of age, but you can't actually predict height very accurately until children get to be older. But it is helpful in terms of, if you see someone who's short and do a bone age which is delayed, you may well be able to tell the family that they've actually got an expected adult height much higher up the centiles and nearer to where you'd expect. In terms of assessing the child, consider things like skeletal dysplasia. Is the child disproportionate? Are there any gastrointestinal problems? Check for thyroid and celiac problems. But I would say that in terms of, you know, children you see for short stature, finding an underlying medical problem is quite unusual, although you should look. But also hypothyroidism and celiac disease are picked up because people do the test for short children, but that might not be the cause of short stature. It's an issue that you see a child who's been seen for short stature, someone's done their celiac antibodies, they're positive, everyone said, great, that's wonderful, start on a gluten-free diet, and everyone's expected then a big spurt of growth, which sometimes just doesn't happen because the celiac disease wasn't the cause of the short stature. In terms of follow-up, it's worth making sure that you follow them up long enough to check that the growth velocity is normal. And if they are actually growing at a normal speed over a reasonable time, they're likely to be healthy, and you don't necessarily need to do more tests. I think families often feel that you need to keep on seeing their child, but just in case something happens. And actually, unless another medical problem intervenes, if someone's demonstrated they've got a normal pattern of growth, you can be happy and you don't need to see them again. You can discharge them. So in this kind of scenario, when would you do growth hormone testing? I certainly wouldn't do growth hormone testing on every child who's short. You would definitely do it if someone was growing slowly over a reasonable period of time and falling off their centiles or with a reduced calculated growth velocity. You do it in that group of patients who come and they're just so short that it seems unlikely that they don't have a problem. Although surprisingly, you find children who are, well below the 0.4 centile and seem to have really no medical problems. And obviously, there's a group of high-risk children who have known pituitary issues, have had surgery, and so on. Often we would do growth hormone testing, as a way of reassuring ourselves if someone was very short for family. But it isn't the case that every single child who is short needs testing. I think in this school age group, there's quite a lot of psychology attached to the way families look at their child's growth. We see quite a lot of children who get referred around the sort of age of 3 or 4, and that's because that's the first time you've seen your child standing up against someone else and someone said, "Oh, your child's a bit short." And it's often the case that families are extremely concerned. You see children, we would do all those basic tests, but part of the psychology is that often a few years later, if you've reassured them the growth's normal, actually parents are often less concerned about their short child. Other things have intervened. There are other ways you look at your child, how they're doing at school, and are they in the football team, and are they playing the piano, and all those things which actually take over from just, well, how big are they? There are a group of people who continue to be concerned, and sometimes that's related to other issues in the child's life. Some of this got covered earlier in the week when we talked, when Dr. Alexander talked about puberty. Constitutional delay and delay of puberty is a very common reason for a referral to a pediatric endocrine clinic. Most of those people are boys, and most of them are children who've been relatively short through childhood. They're now a bit late in puberty, and they have fallen behind everyone else in terms of their growth. Typically like that. They often have, they're often the children of not particularly tall parents, but suddenly they've got to 13 or 14, there are kids in their class who are already 6 foot tall, and they come concerned. Most people have worked out that the problem is that they're late in puberty. When you look at the growth chart, it's worth realizing that that sort of bit of the growth chart, which is around puberty, is an average. So it's an average of everyone who's developed very early and very late. And so there's a sort of relative smoothing out of that curve. And kind of real individual people will grow in a different way. There are various other versions of the growth chart that actually try to sort of take into account that that sort of variation in pubertal state time. Looking at these individuals, once again, you'd think about, well, have they got some underlying problem? I won't go into that at length because we've already had a talk about this. This is a group where sometimes offering treatment with sex steroids with testosterone can help in terms of catching up. It doesn't change final height. Quite a lot of the children we see in clinic really aren't actually short. We quite often see people who are referred who are just on the lower, children on the lower centiles for of the chart. They may be a bit short for their families, but actually they're within the normal range. And obviously, a child who's growing normally, healthy on examination, is pretty unlikely to have an underlying endocrine problem. And often with these children, you want to avoid doing extensive tests. And I've got a cupboards full of growth charts from children in that kind of position. They are on the 9th or the 25th centile. They're a bit short for their family, and there are concerns about their growth. You would go through all the same things of examining the child. As I said, you wouldn't necessarily always do tests on someone that's completely normal. Quite often I do baseline bloods to check that I've excluded obvious things. And when you're talking to the family, I would always think about explaining the growth chart carefully. It's interesting that even some really quite bright people, you realize you see families for year after year, and they have absolutely never understood the concept on the growth chart about normal variation in the population. We've all had the family who sticks their finger on the chart and says, well, where should they be? And that's a sort of impossible question. I would generally offer to follow up these children to check their growth velocity to make sure it is normal. And obviously, if it's not normal, even if they're on the 9th centile, you would want to investigate that. If this child is falling through the centiles, even from somewhere within the normal range, that's not what you'd expect, and you need to investigate. However, that's very rare. I would say we often need to manage people's expectations. I've taken to very confidently telling people that I don't think there's going to be a treatment to make their child taller, because otherwise families will come back and back just hoping that one day I'm going to come up with the answer and give them the treatment. And it's worth making sure that you communicate, say they're normal. And obviously, I realise that in the endocrine clinic, we get a selected group. There are people who've seen their GPs or then gone on to see other paediatricians, and they're still concerned, so they've come to see us. And most people who are in that position do this, and that's normal, and that indicates that they've got normal growth hormone testing. One of the discussions you have is, don't they need a growth hormone test just in case, doctor? And well, in that situation, no, they don't, because that's a test of their growth hormone, and that's normal. And one of the things in terms of people coming to clinic, I think it's noticeable over the years, we now have people who come to the endocrine clinic not really wanting any kind of medical assessment. They don't want me to examine their child or test them for anything or find out if there's anything wrong. They just come, sit down and say they'd like growth hormone now. And I have to explain why actually, no, we can't necessarily do that, and I can't necessarily provide that. So tall stature used to be common, and we don't see it very often, and that's all about social change. If you look back at sort of old literature, it was very common in the 1960s and 70s for girls to be treated to limit their adult height, because it was felt that their sort of lives would be miserable if they were tall. They'd never get their man, and it would be dreadful. And actually, society has changed, and people don't think that. So we really don't see people very often. You can reduce adult height by giving sex steroids to mature epiphyses and limit pubertal growth spurt. And that still occasionally happens, but it's a very rare intervention in unusual situations. The commonest referral for tall stature is for girls who've had relatively early puberty, and often they're pretty near to their adult height already. When you see someone with tall stature, the most important thing to think about is, where are they in puberty? Someone who's completed their pubertal growth is actually likely to have almost completed their growth in height. If you see a younger child, you need to think about whether they've got precocious puberty, which would result in relative tall stature. in terms of genetic things to think of, Marfan syndrome and a few other syndromes of overgrowth. This is a situation where doing a bone age can be very helpful in assessing what the final height's going to be, how much they've got left, and reassure people quite often that there isn't much growth. Growth hormone excess related to a pituitary tumour is a very rare cause of tall stature. That will be characterised by tall stature and rapid growth from a relatively early stage. Sometimes those individuals would have a high IGF-1 level, and the test that you would do would be to start out by doing a glucose tolerance test to see if growth hormone is suppressed by an oral glucose load. And those pituitary tumours are the kind of things that are the problem for the sort of Guinness Book of Record, world's tallest men or women. And as I said, commonest group of people who come with tall stature are girls. They've had a relatively early puberty and they are the tallest in the class, relatively tall. Often by the time they come, they've already started their periods and they haven't got much growth to come. Part of the reason they come is, their parents have been measuring them. They've grown like 10 centimeters in the last year. And someone always tells them that girls don't stop growing until they're 16. And so they calculate that, their daughter, if they grow 10 centimeters a year and they stop growing when they're 16, is going to be like 7'3". And so that's why they've come to clinic. And quite often you can reassure people that they've got a little bit left. They're just going to end up a tall person and there is not a big concern. So moving on to, well, what can we do about growth? What treatments are available in terms of improving growth and improving adult height? And that's something obviously we spend a lot of time talking about in clinic. Obviously, you manage underlying medical conditions, you treat things like hypothyroidism, although to be honest, quite often those things managing may not change height. One of the issues that occurs quite regularly is you see children who are in childhood who in their sort of earlier years had all sorts of medical problems. They were preterm, they had gut problems, they had multiple surgeries, and those children quite often have taken a hit in terms of their height potential. And even if there is a little bit of catch up, that might not have been total. Sometimes families find it quite difficult to accept that if you fix the medical problem, you haven't kind of reversed time in terms of growth. Going back to the pubertal issues, one of a treatment which is often very, very much accepted and people are often happy to have had is giving sex steroids, and that's mainly testosterone for pubertal delay. There's no change in adult height, but there's an acceleration in pubertal growth. And for that group of boys where they're very concerned about their growth, they're feeling very left behind, that can be of great benefit. So that really leaves us with growth hormone. Obviously, you probably know that you can get recombinant IGF-1 for individuals with growth hormone receptor defects and IGF-1 defects, but and then there are a number of investigation medications. There's a trial in achondroplasia, but all of those are quite small print and not very common. And mainly when we're talking about growth, we're talking about growth hormone. Growth hormone treatment was introduced in the 1960s as pituitary extracted growth hormone, and recombinant growth hormone has been around since the mid-1980s. So there is a reasonable amount of experience. And in the UK, the licensed indications for growth hormone treatment are on this list. And that's licensed in UK and under the European Medicines Agency and approved by NICE. Obviously, the primary and the first use of growth hormone was to treat growth hormone deficiency. And this list of conditions is a group of conditions where studies have shown that there is an increment in adult height related to growth hormone treatment. The one thing to point out is in Prader-Willi syndrome, although there is an increment in height, the primary benefit seems to be to muscle tone and exercise ability. The most recent addition to this list is treatment for short stature secondary to IUGR under certain circumstances if there's been a failure to catch up by 4 years of age. And just to show you a growth chart, this is absolutely classical growth hormone deficiency. This is a boy who actually was referred to clinic for a different reason, appeared to be relatively short for his family, grew poorly, had growth hormone stimulation testing, which was abnormal. And he has done what you would expect, which is he's had a period of catch up and is now growing along a line where you would expect for his family. For individuals like that, there's a big difference in height. Untreated growth hormone deficiency results in an adult height in the sort of 130 centimeters range. And so here's someone who's going to be completely normal. And the treatment of growth hormone deficiency gives you a much bigger increment in height for a smaller dose than all of the other indications. And it's important to say that actually it is not the case that any child given growth hormone will grow faster or any child given growth hormone will end up taller. There is only a limited group where that's the case. This is a child's growth chart who came from abroad on growth hormone treatment, had a number of tests of growth hormone secretion, which were all normal. So this is idiopathic short stature, although she's within the range for her family. Growth hormone was started and actually has had no effect on growth rate, hasn't changed anything, although I'm absolutely sure they took it. And on the basis of that, after discussion, it was stopped. The current licensings for growth hormone is that those indications are where there's evidence that treatment will give a reasonable increment in adult height. And one of the areas where there's a lot of discussion, families find out about this, is that there is a difference in the licensing between Europe and the US. And that's because there's a slightly different approach to prescribing and to medications. The difference is that in the US, there is a license for idiopathic short stature, and that is for people whose height is below the 0.4th centile and who have a poor predicted adult height. And that difference is based on exactly the same group of studies. It's just that actually the European Medicines Agency felt that the increment in height in those studies of idiopathic short stature was not sufficient to justify treating. And one of the issues around this is to say that license in the US is based on, children who are very short. And of course, what the sort of knock-on effect is that in the US and worldwide, there are quite a lot of children who are being treated with growth hormone who don't fall into that category. The families whose child's on the 9th centile who want a bit of growth hormone. In some parts of the world, that's possible. In the UK, it's not licensed and it's not usually something that would be forthcoming. It's worth saying that those studies, the research into idiopathic short stature, looked at only children who were very short. And that's because kind of ethically, you can't do a research study on children who are completely normal. So there have not been studies looking at the effect of growth hormone on the adult height of children who are, say, on the 9th or the 25th centile. There are children out there being treated, but they're not part of a research study. All the evidence we have says that it's not worth doing, and it's not something that's going to give you any increase in height. In individuals who have other causes for their short stature, who have a range of genetic causes or other medical issues going on, it is not necessarily the case that giving them growth hormone is going to change their growth pattern or indeed give them a taller adult height. And one of the issues around sort of interpreting what we do is that actually, although there have been a lot of studies of growth hormone treatment in a wide range of short stature conditions, growth hormone research is expensive, takes a long time, and in general has only been done by growth hormone companies. Many of the studies around have not been randomized. And many of them have been of relatively poor quality, looking, for example, at increment in height over height prediction, which has quite a lot of problems to it. And as I said, there have been quite a lot of studies of growth hormone treatment in idiopathic short stature, but none for children within the normal range. And it's worth also saying that most studies of growth hormone treatment have looked at increment in height and increment in adult height. Do you get taller? And as I said, for people with growth hormone deficiency, that increment's quite big. It's sort of 20 centimeters, maybe a bit more. For some of the other indications, that increment is less. For Turner syndrome and for IUGR, it's 4 to 8 centimeters in adult height. There have been studies looking at people who on growth hormone treatment, saying, well, has it improved their quality of life? Well, people who get treatment say they're happy with it. What there isn't much information about, and what is, I think, quite tricky, is that we don't really know what the impact of those increments in height are on quality of life as an adult. Meaning that, if growth hormone treatment gives you 4 centimeters in height, actually, is that increase in height worthwhile? When you're 25, is that going to have an impact on your life? And I think that's quite difficult. You meet families who say that, yes, even half a centimeter is worth it, doctor, but that cannot be so. And I think it's a very difficult area which I can't see being addressed very soon. Anyway, to wind up, in terms of managing children with growth hormone, with growth concerns, looking at the pattern of growth is the most helpful test. Following children for a while, checking their pattern of growth is normal. And although then there are a number of serious underlying conditions you don't want to miss, you don't want to miss growth hormone deficiency. But if actually you do all those basic things at the start and follow the child off for long enough, you're not likely to miss them. And I think, I spend a lot of time talking to families about why I can't make their child taller. And I think it's helpful to try and, I've learned sort of communication tactics in terms of, I'm always trying to be very clear to people that I don't think that there's going to be a treatment that will make their child taller. And I'll also explain to families that I'll want to follow them up for a reasonable period of time. Often that's very reassuring that you're not going to just say, that's fine, go away. You're going to follow them and check that everything is okay. I think a lot of families really don't get the growth charts, and it's important to actually tell them where you expect them to be the next time. There are definitely families where, their child's on a lower centile and they really do go on expecting that somehow the next time they'll have a spurt of growth and be average. And it's important to make sure that that's not what's going to happen, but also to tell them roughly where their child might end up, in that sometimes people have very pessimistic views of where their child's height might be. I think it's important to kind of avoid using very loose terms about what's happening. Someone who's short is not necessarily growing slowly, so it's important not to say that. Faltering growth is not the same as short stature. And I'm always very careful when I write letters. If someone isn't actually short, I'll write concerns about growth rather than short stature. I think that's the final slide. Thanks very much. Any questions?
Thanks very much, Nicola. That was a brilliant overview, some really practical, helpful tips.
Start. You know that. Oh well.
Hello. Sorry. And if anyone had any questions for Nicola, you can either unmute yourself and ask or post in the chat. I was wondering, Nicola, how long do you treat with growth hormone? Do you stop at the onset of puberty or at the end of puberty?
We generally, there's actually a sort of guidance about when you stop, which is basically when things slow down.
And are you aiming for the same growth velocity as a normal child?
What? No. They'd have to go on with it until they get to the end of growth.
Okay.
And in people with growth hormone deficiency, you'd normally retest them at the end of growth to see if they still had growth hormone deficiency, because surprisingly for some people it resolves.
Great, thank you.
Hello, this is Wales Hospital. Just one question, please, about the growth hormone testing. Don't we need to do any stimulation for the growth hormone, or is it sufficient to do only IGF-1?
As I said, yeah, IGF-1 is a kind of marker, and it's helpful, but it's, if you were going to start growth hormone treatment or consider it, you'd have to do a growth hormone stimulation test. That's a given. IGF-1 is not very closely related to growth hormone, so you can be fooled by it. And yes, if you thought you were going to treat someone or were considering treating someone with growth hormone, you'd have to do a stimulation test. And I suppose one of the other things is you wouldn't do a stimulation test if you thought you wouldn't treat them with growth hormone.
Sure. One last thing, about this one. We get those sometimes in the clinic. If they've got, especially girls who are overweight, and they come frequently tall as well. And it looks like the exogenous obesity associated with a bit tall stature. But do we sort of FSH, LH, those sort of things? Do we need to check for them as well? They're normally normal, and their bone age is normally advanced for their age. So, what would be your strategy for managing those?
I mean, most of them, apart from saying try and lose some weight, most of them don't actually need anything doing. Yes, if you're overweight, you tend to be tall with an advanced bone age, and you tend to have earlier puberty. Almost always that's within the normal range early, so it's not a big issue. Obviously, if you saw someone where they were developing earlier, you do FSH and LH. And I think I'd also say that sometimes you see people where it's pretty hard to know whether they're in puberty or not because they're overweight.
Thank you.
Could I just ask a question about late effects in terms of those of you that had intracranial lesions resected or radiotherapy? Do they behave a little bit more like the growth hormone deficient children, or more like those with other causes of short stature?
They behave more like growth hormone deficient children. Depending on what the sort of insult is, children who've had things like radiotherapy and chemotherapy have a very high incidence of growth hormone deficiency, and then yes, can actually be treated and they will get catch up. Obviously, there are situations where people have a bit bigger hit, like, there's quite a lot of literature around craniopharyngioma where, as well as losing pituitary hormones, people lose hypothalamic function as well, and so have sort of other things going on. But yes, pituitary, that kind of group, they have a higher incidence of pituitary hormone deficiency, which can be treated, yes.